Yes, I
I
do.
got it.
Yes, I do.
Yeah, it's up now.
Okay, great.
It's
All
up
right.
now.
So sorry about that, everyone. We were having a hard time getting the recording to start here. But as I mentioned, this is a new setup for me. So this is very unusual that I have this particular setup, and evidently I was having some technical problems. So welcome to our webinar, Conquer CMS Domain 5 Attestation Requirements with Patient Family Advisory Councils. This is actually the 7th webinar in our Get a Black Belt in PFAC series. That's named for my black belt in karate, specifically Taekwondo, which I trained for in many years. And you can watch the others on our YouTube channel, Healthcare PX. So I'm Barbara Lewis, and joining me today is Dr. Stephanie Almaden. She is an established leader in healthcare. She's served as in executive leadership roles. She's an avid speaker. She has managed multi-million-dollar budgets, and she is the founder of the Almaden Group, consulting and transitional leadership firm. She's a published author, editor, reviewer, and speaker, and she has a PhD in health services with management and health policy specialization and a dual master's in nursing administration. So today we're going to cover all of the domains, just very briefly. There's 5 domains in the Centers for Medicare and Medicaid Services, and we're specifically going to focus on Domain 5, which is Patient and Family Advisory Councils. And I'm talking to more and more people associated with patient family advisory councils, such as liaisons, and they're working with others in their organization, leaders, to make sure that this 5th domain is attested yes for. Okay, Stephanie, why don't you kick us off with one of your favorite quotes here?
Well, good morning or good afternoon, depending on where you're joining us. I want to start by thanking Barbara for inviting me to this discussion group, as well as thank you for sharing time of your day with us. As Barbara said, this is one of my favorite quotes that ties to this topic. It was in the Declaration to Advance Patient Safety in the National Steering Committee for Patient Safety publication. And you'll see why it is my favorite as we proceed further in this discussion. It's the responsibility of every executive and governance leader in healthcare to commit to the moral, non-negotiable core value of safety for all, and to foster collective action to uphold this value. So, next, please.
So, Stephanie, why don't you give us an overview of the 5 domains?
So, CMS came out with 5 patient safety structural measures domains. We refer to them going forward as PSSM. And these are domains of attestation that all hospitals across the country are supposed to report on. The first is leadership, as you can see, leadership commitment to eliminate preventable harm. And we'll talk more about that. The strategic planning and organizational policy for the hospitals, the cultural safety and learning management system, accountability and transparency. You see where this is all leading to that favorite quote eventually. And the 5th domain being patient and family engagement, where the patient family advisory councils reside. And that's our focus for the day. Now, each domain will be having a score of 1 point. So when you attest that you have implemented the requirements for each domain, there are many. but only 1 point that the domain will get for a total of 5 points. And it's very critical because in 2027, reimbursement will reflect where you were on that scale. So it does impact reimbursements in 2027. This slide is about those 5 domains, and it's really more of a 30,000 view of the area of impact for each domain within the hospital system. We're not going to go in details through all these items or elements within the domain, but I'll just use the first one as an example. Because of the leadership commitment to eliminate harm, it's going to impact performance reviews focusing on patient safety, as well as 20% of the leadership safety initiative tying into patient safety, patient satisfaction. And also you see it on their agendas as meeting. And that's not just at the highest level, that is at every department level, every operational areas. So you see why it has to be, patient safety has to be hardwired system-wide. And of course, the adverse events reporting within 72 hours. The last column is more of, recommendation in terms of potential metrics, but we will be going through that in more details.
So today we're going to focus on domain 5 specifically, and that's patient and family engagement. So tell us about that, Stephanie.
So here, the focus, as I just mentioned, is patient-centered care and patient safety. So bear with me as we go through this, try to think what's going on in the hospital you're attached to. Think always in metrics and trends, what is surfacing, which area, because different operational areas have different, procedures and challenges. So keep that in mind. PFAC is evidence-based strategy to enhance the patient's experience, safety, as well as organizational outcomes. As I said, this is going to eventually tie to reimbursements for the hospitals. Hospitals' compliance with CMS domains became actually effective beginning of last year. As you know, typical of CMS, they gather data, and before they make anything effective, they define the grounds they're standing on and the expectations from systems. The first reporting period, even though it became effective at the beginning of last year, but the first reporting period is slated for June of this year. And the results will be reported to the public on CMS Hospital Compare as of October of this year. And hospitals that fail to report will face annual payment reductions next year. So the question you should be asking now, are we ready? So let's see. This slide is basically about telling you why we are here today. This patient-centered care and patient safety has a history that started back in 2001. I'm sure everybody remembers the Institute of Medicine, now National Academy of Medicine, seminal publication, The Triple Aim, and its focus on patient safety and satisfaction with care, population health at the time, as well as reducing the per capita cost of care. And at that time, also this STEEP initiative the Agency for Health Research and Quality came out for quality domains: the safe, timely, effective, efficient, equitable, and the P for patient-centered. And we thought that started something concerning patient safety, but then in 2005, the Patient Safety and Quality Improvement Act came about. And there also, the first two items in that act were concerned with patient safety and patient satisfaction, patient-centered care. And what is critical about this is that it started shifting focus of control from the system to the patient safe and satisfaction with care. And then 2010, the Affordable Care Act, Patient Protection Affordable Care Act came out and basically emphasized the same issue. And I'm just quoting here the 3 points or 3 items I'm quoting are in relevance to patient safety and patient satisfaction. And then despite this movement, still in 2018, the Health and Human Services comes out with the report that patient admissions, 24% of admissions have caused harm to patients. And the tough challenge here is that 40% of that were preventable. So you see why the safety issue is critical right now to make the changes with these PSS domains. The pandemic hit, we all know what happened in terms of certain ethnic, racial, vulnerable population being at a disproportionate disadvantage in terms of harm and preventable harm. But the most critical now, and what you will find useful as we proceed, is the National Steering Committee, as I said, co-chaired with the Institute for Healthcare Improvement in 2022, came up with the National Action Plan, and I've updated it further in 2024. So here the focus shift, before we move on, the focus shift now is critical, moving from worrying about reimbursement payment bundles. Think of it as patient safety bundles because it has to be system-wide. Focusing on transitional care, diagnostic errors, particularly with AI infiltrating healthcare. So behaviors are also a focus in this phase. Next, please.
So each of the 5 domains has 5 statements associated with it, and you have to attest to all 5 statements, yes, before you get 1 point for each domain. So there's a total of 5 points. And as Stephanie mentioned, that's going to be associated with money and reimbursement. So these are the 5 statements that are specific in domain 5, and we're going to go over them. Stephanie, anything to add here?
Yeah, a couple of things I want to add. We're going to go statement by statement and connect that to what the data is showing. But also the other point is, keep in mind, they all have to be met. There is no partial credit. It's either 1 point or nothing if something is not met. Next.
So I'm going to be weaving some of the research that I've done. I have actually been researching patient and family advisory councils for the past 10 years. And I originally did research. I started 10 years ago, and it was published by the Barrow Institute. And then a few years ago, I was thinking, well, that research is getting a little old. So why don't I go back to school and get a PhD? And I did it during the pandemic. And if you ever think about going back to school, I highly recommend it. My brain expanded, which was really nice. And my dissertation was on patient and family advisory councils. So I did 3 studies. I did a literature review of articles from around the world and looked at hundreds of them and narrowed it to 143 articles that specifically talked about patient and family advisory councils. Then in my qualitative study, I interviewed 20 hospitals, the leaders, about what they were doing with PFACs. And in the quantitative study, 220 people answered the survey, and these people worked for US hospitals. And all of these articles have been published as a trilogy in the Journal for Patient Experience. So I'm going to be talking about some of this research as we go through each of the statements, the 5 statements associated with domain 5.
Yeah. So the first one here, statement A, the first part of it, our hospital has a patient and family advisory council. So this is one of those items that you're attesting for.
And what the American Hospital Association data shows, they asked this question since 2018, does your hospital have an established PFAC that meets regularly to actively engage the perspective of patients and families? And you can see that the first year in 2018, the percentage of hospitals that had PFACs was 54%. It went up, and then we hit the pandemic and it dropped down to 51%. It's going back up, and every December, I'm very fortunate that the American Hospital Association sends me this data. So in 2025, I was looking for 2024 data. So last December, a few months ago, I contacted them and asked them for their data. And they said, oh, we didn't think that that was a question that we needed to have. And we eliminated it along with a bunch of other questions too. So I lobbied them, and I told them that they were the only organization that was tracking this in the country, and that it's very important to hear how the patient voice is embedded in hospitals. And this particular question on their annual survey is very important. So they added it back. And so I am going to get the 2025 data in December of this year. And they also added a couple of other questions about patient family advisory councils that I asked them to include. I figured, why should I ask for one? I might as well swing for the fences and ask for a few questions. And they were very agreeable about it. So I was very happy to hear about that. So this is the average that the American Hospital Association lists here. But when I sliced the data, I found that 75% of children's hospitals have patient family, or they have what's called a parent and family, or just a family advisory council. And in fact, in my research, I found that in 1982, the first PFAC in the country was at Boston Children's Hospital. Now, you may know that Massachusetts is the first and only hospital. In 2010, this happened, where they passed a law that all hospitals have to have a patient family advisory council. And Rhode Island, right next door, also has 100% of their hospitals have a PFAC. And then we drop to the other end of the scale and find that states differ as well. And the state of Idaho has the lowest percentage of hospitals with a PFAC, and that's 13%. So our recommendation here is that you start a PFAC, and there's lots of resources. And I've got a ton of resources, toolkits and things on my website to help start and strengthen PFACs. And that what I found in the dissertation research was that if you have a PFAC by the department, or by condition, or by population, such as youth or senior citizen, for example, that the PFAC is more successful than an overall hospital-wide PFAC. So let's go on to another part of the statement in this statement A, another phrase here.
Okay, so here it's in terms of input, the PFAC having input to the safety-related activities, including representation on board meetings. They consult the patient or family or caregivers on the safety goal setting and metrics, as well as having them participate in safety improvement initiatives.
And what I found in the research in this is that the level of support that you have from the C-suite, that is the CEO, the CNO, the CFO, et cetera, that the PFAC is more likely to be dealing with safety issues. So, for example, I heard that in one system, the vice president, the regional vice president, said that to everybody in the organization, if you're bringing an initiative to my office to approve, you have to have a patient voice involved. So when you have that kind of support from the C-suite, it really helps in terms of looking at all the different initiatives, safety related, et cetera, and working on putting the patient voice. So the recommendation here is that all patient-facing initiatives have patient input. If anything has to do with the patient, let's ask the patient. And this has not been common in hospitals, but if you fly, if you buy a car, if you buy a computer, no matter what you do in any industry, they're going to send you a survey and ask you for feedback. But we haven't been doing that in hospitals for a long time. But now that money is attached to the HCAPs, for example, and now the CMS attestations, hospitals are looking around and saying, we need to get the patient voice here. So we're still in statement A, and this is, do you have representation of the board members? And the research results here are not particularly good to get excited about, let's say. Some things I was very excited about and some were kind of sad. So only 12% of hospitals responded that they have a PFAC member on the board. But this is probably going to change now because we have this statement A that says there is representation at the board meeting. So the recommendation here is to train at least 2 PFAC members to attend board meetings. And research shows that if you have 2 people, they're more likely to speak up. If you have 1 person representing, for example, the PFAC, that person may not be likely to speak up because they're just the only person and there's a certain amount of pressure. But oftentimes 2 people, that will happen and it'll be great representation.
Before we move on, I just want to interject something here, procedural, just knowing how the system works. Here, it's very important for the hospital to re-examine the escalation policy when there is a complaint or a patient or caregiver raises an issue. Because of the involvement, of leadership, it shows. So that's one example of data gathering you can have. And the second here, procedural, because you have 2 PFAC member, which is ideal so that you always have representation, you need to also decide, are they voting members or non-voting members, more like advisors. So it depends on your facility how you choose that path. But 2 will always ascertain coverage of a PFAC representation because of the timing, life happens. So you always want to have some representation on the board meeting.
Right, good point, that it's not just the fact that there should be 2 because there's less pressure to speak up and more likely to speak up, but also in case 1 person can't make it, at least the second person will be able to.
Yeah.
Okay, let's move on to statement B.
Our hospital's Patient and Family Advisory Council includes patients and caregivers of patients who are actually representative of the patient population that the hospital serves. So,
And this was not really great information. I mean, it was quite interesting, but it was a little sad, this. How well do the demographics of your PFAC match the hospital's demographic? An excellent match, only 3%, a good match, 44%. But you see down here, poor match and fair match is quite a lot. So the way that hospitals are dealing with this, because many hospitals have told me that it's basically retired people who are on the PFAC, and that's very intuitive because they have the time to devote to going to meetings, etc. But what we recommend, and what a lot of hospitals are doing, is they're using their electronic health record to reflect the demographic catchment. So they're saying, okay, we need this group or that group. And then they go out and they ask people that fulfill those demographics if they're interested in being on a PFAC. And of course, those demographics have to be updated periodically, assuming that the catchment area may change or something like that. So,
and one more thing here, I'd like to interject. Also, another source of data is the marketing surveys that hospitals conduct every 3 to 5 years, because we all know there's always shifting demographics. So that speaks more to the point of how you update your PFAC membership and how you define the term of service for the PFAC members, because you always have to keep in mind they have to represent the community the hospital is providing services in. And the Department of Public Health for the state also conducts surveys and posts data about regions and different areas and the demographics of these areas. Just
so you
something
could
to
use
keep in mind.
you could use that information then but
Yeah.
usually hospitals know their demographics and have that information.
Yeah, from the EHR. Yeah.
Okay, so Stephanie, tell us about statement C. This is the third statement in the domain number 5, patient and family engagement.
Yes. And that's obviously about patients having comprehensive access to and are encouraged to view their own medical records and clinician notes via patient portals and other options. And the hospital provides support to help patients interpret information that's appropriate, as well as submit comments for potential correction to their records. I think many have seen that happen in patient portals as systems upgrade their systems or merge with another entity and migrate data. There's always bound to be some errors, so you gotta give the patient the chance to correct these errors. Over 80% of hospitals offer patients access to clinical notes via the portals. That's what the statistics is showing. They see after visit summary, or they see their history and physical information or result of an MRI or X-ray. The adoption of this obviously first was started with the High-Tech Act of 2009, and then it was anchored by the 21st Century Cures Act. Over 260 health systems now, 54 million patients participated in the voluntary open notes initiative to enhance, this project of access to the medical information in their records. And as you see in the graph, it shows you that about 77% actually offer this online access to medical records by providers and insurer. And the proxy, when it's not the patient accessing the record, but rather a caregiver, only 51% do so. So we're making progress, but not quite there. We should be more at 100%. Next.
And let's move on to the fourth statement, statement D.
This one about you're attesting that the hospital incorporates patient and caregiver input about patient safety events or issues such as submission of safety events, safety signals from patient complaints, or other patient safety experience data and reports of discrimination. See, this is in reference to how you handle basically complaints, grievances, and how you correct them.
So PFAC evolution is very interesting. So years ago, the PFAC was basically the member gripes, but that changed probably about maybe 8 or 10 years ago, where the hospital didn't necessarily want to go into a meeting and listen to people griping only, but they started to have a lot of questions on their own that they wanted to use the PFAC sort of as a focus group to have discussions about various things. So the hospital wanted feedback. And now a lot of hospitals have both. If a member has a complaint, they can put it into a portal, and then it will be considered for the agenda. But basically, as the visibilities of patient family advisory councils have increased, the hospital departments have come to the PFAC and said, we'd like to know about this, or what about the discharge directions, or whatever it is. And according to my research, there's a wide range of topics that come to the PFAC, although the majority of them oftentimes are communication. So there's 3 levels of engagement that I found in my research, both in the research that I did with the literature review and also the quantitative research that I did. And I divided the level of engagement with PFACs into 3 different areas. One was the stamp of approval, and this is where a department comes, the brochure has been done already, we want you to sign off on it. And very few hospitals are using this predominantly as their way that they interact with PFACs. Only 3% I found, both in the literature review, and it was confirmed also in the quantitative study that I did. In fact, some hospitals ban stamp of approval. And as one person said to me, this is not very respectful of their feedback and of their time to just come in and say, here's what we've done, we want your stamp of approval. Then as we move up the ladder for more involved engagement, we find that the majority, 65%, fall into the feedback. And this is where the department is moving along in a particular initiative, but they want to get feedback from people and they want more input during the progress. And the last one, which is the highest level of engagement, but only used by 24% of hospitals predominantly, according to the survey, is that the PFAC is involved at the inception of the project. Here's a problem that we have, help us solve it, and what should we do about it? So, Stephanie, let's move on to the final and last statement of the Domain 5, Statement E.
So here, essentially, you're attesting that the hospital supports the presence of family and other designated persons as defined by the patient as essential members of a safe care team, and encourages engagement in activities such as bedside rounding, shift reporting, discharge planning, and 24/7 visitation as feasible. So the data shows that at this point, 65% of US hospitals have 24-hour visiting hours. That's by the Health and Human Services reports. And around 80% of hospitals let the patient define the family. In California, it was actually a bill that was enacted by the Assembly in California, where the patient define who their designated family member is. And it's been in implementation now for quite some time.
Okay, so those are the 5 domains. And as I mentioned, I'm talking to more and more people who are liaisons and associated with patient family advisory councils, and they're working with their leaders to make sure that all 5 of these statements they can attest to, so that the hospital achieves the 1 point. Remember that, as Stephanie said, there is no partial points. So you have to attest to all 5 and say that this is what you're doing. And then you get 1 point for domain 5. And then you get 1 point also on the other 5 statements that are associated with domains 1, 2, 3, and 4. So Stephanie, tell us about some resources.
Okay, so this resource, I wanted just a slide just for this resource because it is critical. This is the National Action Plan to Advance Patient Safety that I mentioned earlier. And please, 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 if you don't read anything, at least read through that, because it has also a self-assessment tool. Remember, I said it came out in 2022, updated in 2024. So if you're involved in this or you have a voice in this, make sure everybody's aware of this assessment tool. Basically what it is, it's a worksheet for you to prepare you for the CMS reporting submission. So you're looking at the readiness, focusing on these areas: culture, leadership, engagement, and safety. You're looking to identify if there are opportunities, areas where there's some weakness, not quite working like it should, and how to improve it, and tracking your own progress over time. Yeah, and you will see what I mean by that when I show you this sampling of the scoring. This assessment tool really aligns with CMS National Quality Strategy, as well as the PSSM domains we're talking about, and the U.S. Department of Health and Human Services National Action Alliance for Patient and Work Safety, and the World Health Organization. It's online, and it reflects maturity, meaning, your growth and development in reaching that stage of hopefully exemplary at some point. The scoring is 1 for as beginning, making progress, or significant impact. And it provides you guidance. Where you see opportunities for improvement, it'll show you guidance on how to improve. And here's a sample. We're not going to go through all the details, but I wanted you to see that, because we keep saying you have to meet all items for each domain to get that 1 point. Not to be confused with the scoring of this tool. Remember, this is a worksheet, and any score you get at the end is a raw score for you to know where you stand and where you need to be and how to get there. So just like, see the care plan engagement, the safety concerns, the escalation process, what I mentioned earlier, because it's very important that you have achieved that level of everybody's awareness with what's going on and how it can be corrected. And this is the raw scoring that I mentioned. So if you're getting yourself scored yourself off this worksheet, 7 to 11, you're in the beginning phase, and recommendation for action, how to correct the issues or improve if it's there but not robust, how to enhance that. And, it's pretty much self-explanatory.
And people can get this, Stephanie, on the IHI website?
Yes, the National Action Plan. Yeah, there's a part that is a self-assessment tool.
Right. Okay, let's move on to recommendations.
So, back to basics, examine the existing reporting system you have in place, because having worked with multiple health systems across the country, I see that, they mean well, but sometimes people settle in their roles and continue to do what they're used to doing. But now it's a different time, and this is a pressing need now because of all the changes we had in health system with AI doing much of the work. So examine existing reporting system in place, what you need to add, modify, or update so that you reflect and able to report on the PSSM metrics for PFACs. And also look at the learning management system, because that also relate to how are you onboarding people, new people coming in, how are you orienting them, and how are you doing your annual training to include PSSM modules and metrics. And reassess the feedback loop closure. It's not enough to flag a problem and address it, but you also have to have it on record, showing that a corrective action plan was done. Document, we all know, not documented, not done. And track the value of your PFAC. I see many systems are being challenged with that, because you have to show evidence of the efforts that are put in place because of the PFAC input and amplifying, as Barbara said, the patient and family voice in your system of care, and measure that return on investment for having the PFACs and how it affected your reimbursement, to perpetuate this over time.
So let me just jump in here and talk a little bit about the research. I found that there's a number of hospitals who are using process metrics, and that's the numbers, the number of meetings, the number of people, the number of initiatives, the number of departments that came. But very few hospitals are using outcome metrics where they're measuring before and after. So let's say you've got the colonoscopy directions that are being rewritten. And the reason is because there's so much fall off when somebody goes up to register for the colonoscopy and they find that they didn't follow the directions. So they say, no, you can't participate today. We'll have to reschedule. So how many times are people turned away before the change in directions, and how many times afterwards? And that's associated with money. But generally what I found in the research is that very few PFACs are measuring the outcomes. And it's really imperative that we measure our success and the value of the PFAC, because when budgets are squeezed and people look around and say, okay, what can we cut? Well, what is the PFAC doing? Oh, some departments come in and talk to them. But if you've got solid evidence about how your input is changing the results and associated with money, that's really important. And I have an article on that was also in the Journal of Patient Experience, that PFAC success is based on metrics. Okay, here are
just before we get to that, one more point is, if you're forming a PFAC or you have a PFAC anticipating adding members, try to put a nurse on the PFAC that is not necessarily a staff nurse, but a nurse who walked the journey as a patient or was a caregiver of a patient, because we can come up with the best plans, but it's how the patient journeys through the system that tells us if the plans were working well or not. Anyway.
And Stephanie is involved in the AARP initiative to have nurses on PFACs, and there's quite a few hospitals now that are adopting that. So yes. Here are the references for you. And
can you keep the references a slide just a while? Because somebody asked and I answered it. of all the references, as I write and speak, here you have the best references you can have on this topic. So I strongly recommend, if you have a chance to make time, read through that. And the assessment tool is right there. You see, let's see, 2, 3, like the 5th or 6th reference, it shows you self-assessment tool, Safer Together.
Yeah. Okay.
Okay.
Great. Yeah. For
Thanks.
people to use.
Yeah.
Okay, so we'll turn to questions and comments, but here is Stephanie's information if you want to contact her. And here is my information as well. If you're watching this webinar and you're with somebody and you didn't get an invitation, here's my email address here. Reach out and send me your information so I can put you on the distribution list. And our next webinar is on May 29th at 9 a.m. And I'm going to try to drop a link in the chat. It's called Get a Black Belt in PFAC, Scale the Patient Voice, Why E-Advisors Matter. And we've got several panelists who are talking about their e-advisor program, some of them that complement PFACs and others that are just standalone programs. I don't expect you to remember this. So let me see if I can stop sharing here and I can drop that in the chat. And also go to the chat. So Stephanie, do you want to open the chat while I'm getting that? And
yeah, I have that open. Yeah.
Okay.
I'm answering. Somebody asked for the contact.
Okay, I'll be there in just a second. I'm going to drop in the e-advisor. Okay, that is so if you want to sign up for that, you can. And that's also to sign up for the recording as well.
Yeah.
Right. Okay. So let me see what else is in the chat here.
Yeah. So there's a question about the membership number of people on a PFAC.
Okay. So I did research on that. And 13 is the average number of volunteers, and 7 was the average number of employees. So you want to make sure that the employee number never exceeds the volunteer number. And I know of some PFACs where this does, and the volunteers just feel overwhelmed. And essentially the meeting is run by the employees. They're talking about their issues, and it's not considering what the volunteers, the patients, and the families.
And if I may add to that, also depends on, is it the PFAC for the whole hospital, or is the PFAC focused on certain operational areas like the emergency room, transitional care, telemetry, or critical care. So it depends.
Stephanie, did you put the link for the tool in?
Well, somebody must have copied it from the reference slide and put it there. Catherine did that.
Okay, thank you, Catherine.
Yeah.
Let's see. I'm going down through. Stephanie, you put your information in there.
Yeah.
Okay, so there will be a link to the recording, but the link that I dropped in is if you want to sign up for the Scale the Patient Voice, Why E-Advisors Matter. And if you want the recording and you can attend, and sign up also, because now what I'll do is I'll send this recording to everybody who signed up for this. And then, okay, is there anything else? Does anyone want to unmute and ask a question or talk about anything? Hopefully you found this educational and helpful. And if you're working with a PFAC, you're at least, hopefully you're aware now of these domain statements. And whoops, who is sharing their screen here?
That's you.
No, I don't.
That's UNLV. That's you. You must have put your cursor some,
Oh,
yeah.
hmm.
Shall I
Okay.
stop the recording or?
Yeah, I think we could stop the recording now. Right.
Okay.
Okay.